Welcome to our video on acute kidney injury. After watching this video on acute kidney injury or AKI, you should be able to discuss the clinical significance, differential diagnosis, evaluation, and management of AKI. You should also be able to promptly recognize, evaluate, and manage AKI. AKI occurs in 25 to 30% of hospitalized patients worldwide. It occurs in 60% of adult patients in the intensive care unit, 20% of whom require kidney replacement therapy, that is dialysis support. The incidence of AKI treated with kidney replacement therapy has more than doubled in the US in recent years. The kidneys are more than just blood filters. They are complex organs that are involved in many vital functions. The kidneys are involved in the regulation of body volume, a multitude of electrolytes, body pH, the renin-angiotensin-aldosterone system, glucose homeostasis, the production of erythropoietin, a hormone responsible for red blood cell production, vitamin D metabolism, and of course, waste and water elimination. Because the kidneys are involved in all aspects of body metabolism, AKI can lead to major complications involving almost every organ. Patients can present with altered mental status, pericarditis, cardiac strain, arrhythmias, hypertension, gastroenteritis, altered glucose metabolism, chronic kidney disease, acute lung injury with pulmonary edema, dysfunction of blood cells including leukocytes and platelets, and of course, reduced survival. AKI is also associated with increased hospital length of stay, direct costs, and most importantly, increased mortality. AKI has been shown to be associated with an increased risk for the development of chronic kidney disease or CKD. What happens when patients with AKI develop CKD, then slowly progress to end-stage kidney disease? Progression of CKD leading to ESKD requiring dialysis can shorten the remaining lifetime by approximately 60 to 70%. This table is taken from the US database analyzing the expected remaining lifetimes of the US population and of dialysis and transplant patients by age, gender, and race. For example, if an individual is in his or her early 20s without kidney disease, this individual is expected to have a remaining lifetime of 57 years. However, if the same individual has end-stage kidney disease requiring dialysis therapy, the remaining lifetime is on average 15 years instead of 57 years. If this individual gets a kidney transplant, the remaining lifetime may be improved from 15 to 38 years. AKI may be defined and staged per the Kidney Disease Improvement Global Outcomes, known as KDIGO. KDIGO is the global nonprofit organization that develops and implements evidence-based clinical practice guidelines for kidney diseases. The definition and staging of AKI depends on the fall in urine output and rise in serum creatinine. The worse the decline in function, the greater the stage. In terms of urine output, a urine output of less than 0.5 ml per kg per hour, lasting 6 to 12 hours defines stage 1. 12 hours or more defines stage 2, and urine output less than 0.3 ml per kg per hour for 24 hours or more, or anuria for 12 hours or more, defines stage 3. In terms of serum creatinine, a serum creatinine increase of 1.5 to 1.9 times baseline over 7 days, or an absolute increase of 0.3 mg per deciliter or greater from baseline over 48 hours defines stage 1. A serum creatinine increase of 2 to 2.9 times baseline defines stage 2. A serum creatinine greater than 3 times baseline, or an increase in serum creatinine to 4 mg per deciliter or greater, or initiation of kidney replacement therapy defines stage 3. For patients aged less than 18, A decline in eGFR to less than 35 defines stage 3. How can we differentiate AKI from chronic kidney disease or CKD when we have a patient who presents with an elevated serum creatinine, but without any historical creatinine values or recent data on urine output? Symptomatically, patients with AKI present feeling acutely ill, whereas patients with CKD may be asymptomatic or only present with non-specific symptoms, such as having low energy, poor appetite, and insomnia, because their body had time to compensate to all the metabolic disturbances associated with CKD. Patients with AKI have relatively normal red blood cell count, whereas patients with CKD tend to present with anemia because of reduced erythropoietin production by the kidneys. Patients with AKI tend to present with high serum potassium levels, whereas serum potassium levels tend to be very normal in patients with CKD, because in CKD, the gut can compensate and increase potassium secretion. Patients with AKI have normal-sized or enlarged kidneys, whereas patients with CKD tend to have normal to small kidneys with renal cortical thinning. Patients with AKI tend to have relatively normal bones, but patients with CKD may present with osteopenia. These are general differences between AKI and CKD. And of course, there are exceptions. It is the job of the astute clinician to tease out exceptions. Examples of exceptions to these general rules include diabetic patients have normal-sized kidneys, not small at end-stage kidney disease. This is because diabetic patients have hyperfiltration, thus enlarged kidneys early on in their disease. Towards end stage, diabetic kidneys return to normal size, not small. Normal or enlarged kidneys may also be seen at end stage in patients with infiltrative diseases such as lymphoproliferative or granulomatous disorders, kidney mass, or cystic disease. Patients with AKI who have acute blood loss can present with anemia. Patients with chronic lung disease with compensatory increase in red blood cell production for their underlying hypoxia can present with normal red blood cell count despite having chronic kidney disease. What kind of kidney injury can we have? To answer this question, we need to ask what are there in the kidneys. We have blood vessels supplying the kidneys. This means we can have kidney injury from severely reduced blood flow to the kidneys for whatever reason. AKI due to renal hypoperfusion is referred to as pre-renal AKI. Within the renal parenchyma, we have glomeruli, tubules, interstitium, and blood vessels, so we can have injury of the glomeruli from a wide range of glomerular diseases, tubulointerstitial nephritis, and also vasculitis or thromboemboli involving blood vessels. These make up intrinsic causes of AKI. Finally, we have the collecting system. So we can have obstruction within the collecting system that can cause AKI. AKI involving the collecting system is called post-renal AKI. We traditionally categorize the underlying etiologies of AKI as pre-renal, intrinsic, or post-renal. Pre-renal refers to any condition that leads to reduced renal perfusion. Intrinsic causes refer to any injury involving the renal parenchyma. Renal parenchyma is made up of glomeruli, tubules, interstitium, and blood vessels. Intrinsic causes of AKI, therefore, can include glomerular diseases, tubulointerstitial diseases, and vascular diseases. Post-renal AKI refers to any condition that can obstruct normal urine flow. Let's first discuss conditions that can lead to pre-renal AKI. For pre-renal AKI, we zoom out and look at the whole body. Conditions that can lead to renal hypoperfusion include those that can lead to total body volume depletion, such as bodily fluid loss or lack of fluid intake, reduced effective circulating volume due to an acute drop in blood pressure, or reduced venous return or cardiac output. Reduced cardiac output could be due to any acute cardiac event, such as a myocardial infarction or acute decompensated heart failure, pericardial effusion, or any acute pulmonary problem that could affect blood return to the heart, or severe nephrotic syndrome, with associated stagnant body volume distributed to the interstitial space instead of circulation. Of note, when there is kidney injury related to poor cardiac output, it is referred to as cardiorenal syndrome. We now zoom into the kidneys and think of conditions that could compromise renal blood flow and glomerular filtration. We start out with the renal artery. We could have renal artery stenosis, going further into the glomeruli and examine intraglomerular hemodynamics. We check for medications that could cause vasoconstriction of afferent arterioles or vasodilatation of efferent arterioles, or both, hepatorenal syndrome with associated severe renal vasoconstriction. Last, we can also have renal hyperperfusion with extrinsic compression of the kidneys, such as large perinephric hematomas known as Page kidney or abdominal compartment syndrome. With poor renal perfusion, there is poor urine flow, thus the buildup of a sticky tubular protein called Tam-Horsfall proteins. These proteins take the form of the tubules and eventually get excreted as hyaline casts. When there is prolonged renal hypoperfusion, renal tubular cells die, slough off, and get excreted into the urine as tubular brownish debris called muddy brown casts. A prolonged prerenal state can lead to acute tubular necrosis or ATN. ATN may also develop from exposure to toxins. Examples of common nephrotoxins that can cause ATN include intravenous contrast, calcineurin inhibitors or CNIs such as cyclosporin and tacrolimus, cisplatin, tenofovir, heavy metals, gentamicin, and amphotericin. Laboratory findings that we may see in prerenal AKI include blood urea nitrogen to creatinine ratio greater than 15 to 20 because urea reabsorption is increased with renal hypoperfusion. Urinalysis may reveal a specific gravity greater than 1.020 because of more avid water reabsorption. This gives rise to a more concentrated urine. The normally undetected low protein concentration in the urine will now become more concentrated and can be now detected as trace. Hyaline casts can also be seen. In severe injury resulting in ATN, muddy brown casts can be seen. There should be no or very minimal albuminuria since there is no glomerular injury. For patients with prerenal AKI who are non-oliguric, defined as having urine output greater than 400 ml per day, a fractional excretion of sodium or FeNA of less than 1%, or a fractional excretion of urea less than 35% may be seen. Note that FeNA may be falsely high in patients taking diuretic because of the sodium wasting with the use of diuretics. For this reason, a fractional excretion of urea should be measured in patients taking diuretics instead of FeNA. Once ATN has occurred, however, FeNA will be greater than 1% and fractional excretion of urea will be greater than 35%. What about post-renal AKI? Post-renal AKI is due to anything that can obstruct urine flow. Post-renal causes of AKI can be divided into structural and functional obstruction. Structural causes of obstruction could be due to extrinsic compression of the collecting system by a large malignant mass or retroperitoneal fibrosis encasing the ureters and blocking urine flow. There can be obstruction within the collecting system by stones, malignancy involving the collecting system, blood clots, or papillary necrosis, or strictures of the draining ureters or urethra due to inflammatory problems with infections or procedural manipulations. Functional obstruction refers to any condition or drug that can alter bladder tone for normal voiding. Common conditions associated with functional obstruction include diabetic neurogenic bladder, paraplegia, and the use of diphenhydramine with anticholinergic activity. Other drugs that can cause functional obstruction include drugs with anticholinergic activity such as tricyclic antidepressants, diphenhydramine that can decrease bladder detrusor muscle contraction, sympathomimetics and alpha adrenergics that can increase the tone in prostate and bladder neck, and NSAIDs that could inhibit prostaglandin-mediated detrusor muscle contraction. To diagnose post-renal AKI, a kidney ultrasound and bladder scan are routinely done to evaluate for obstruction and urinary retention. Kidney ultrasound may reveal anything from pelvic fullness and pelviectasis in mild obstruction to hydronephrosis in severe obstruction. Routine chemistry may reveal hyperkalemia and metabolic acidosis out of proportion to the degree of kidney failure. This is because urinary stasis can lead to the loss of the favorable electrical chemical gradient necessary for optimal potassium and hydrogen secretion at the collecting duct. On urine analysis, the urine may be bland or active with white and/or red blood cells if there is any active irritation or inflammation, and/or crystals if there is microtubular obstruction from crystallizations of stones or drugs. What about intrinsic causes of AKI? Within the renal parenchyma, we have glomeruli, tubules, interstitium, and blood vessels. So we can have injury in the glomeruli from a wide range of glomerular diseases, tubulointerstitial nephritis, and also vasculitis, and thromboemboli involving blood vessels. Glomerular diseases can present with AKI. Some glomerular diseases are known to progress very rapidly and are known collectively as rapidly progressive glomerulonephritis or RPGN. And then there are other glomerular diseases that tend to progress more slowly but can still present with AKI for different reasons. When do glomerular diseases give rise to AKI? AKI associated with underlying GN may occur with both nephrotic and nephritic syndromes. However, the mechanisms may be different. For patients with nephrotic GN, AKI may occur due to severe anasarca with associated edematous kidneys, leading to reduced renal perfusion, complications of treatment such as ovodiuresis or nephrotoxic levels of calcineurin inhibitors, development of renal vein thrombosis, or pulmonary embolism affecting cardiac output, or in some cases, aggressive progression of the underlying disease. In addition to optimization of fluid status and medical therapy, a renal vein Doppler may be considered when we have a patient with nephrotic syndrome who presents with AKI. For patients with nephritic GN, AKI is more likely due to the aggressive progression of the disease itself, but can also be related to complications associated with medical therapy. Evaluation for GNs associated with nephritic syndrome should be done in any patient with AKI and an active urinary sediment. When we have a patient with AKI and an active urinary sediment, we should consider an RPGN. Categorization of RPGN is based on findings on immunofluorescence microscopy or IF. If we see an essentially black field without much immunofluorescence, it means we don't have much deposits or post-immune. If we see non-specific scattered immunofluorescence, we can think of immune complex or complement-mediated glomerular diseases, depending on whether we tag against immunoglobulins or complements. If we see a nice linear pattern, it suggests the presence of immunoglobulin depositions all along the GBM or anti-GBM disease. Based on our findings on immunofluorescence microscopy, we can think of these differential diagnoses. For post-immune GNs, we think of ANCA vasculitides, which include granulomatous polyangiitis or GPA, microscopic polyangiitis or MPA, eosinophilic GPA, or renal-limited ANCA vasculitis. For immune complex-mediated GN, we have lupus nephritis, IgA nephropathy, a number of glomerular diseases with the membranoproliferative pattern of injury, and the rare fibrillary or immunotactoid glomerulonephropathy. For complement-mediated GN, we have C3 glomerulonephropathy and post-infectious GN. For anti-GBM disease, we have good pastures disease if both lungs and kidneys are involved, or anti-GBM disease if only kidneys are involved. So based on these differential diagnoses, when we suspect a rapidly progressive GN, we routinely obtain ANCA, anti-GBM, ANA, and complements. Of course, the definitive diagnosis is in a kidney biopsy. If AKI is due to a rapidly progressive glomerulonephritis, urine analysis will likely be notable for some degree of proteinuria, presence of dysmorphic red blood cells, red blood cell casts, and/or granular casts. Because RPGN injures glomerular basement membrane, patients will also have albuminuria. The urine albumin to creatinine ratio will be elevated. Intrinsic causes of AKI can include tubulointerstitial diseases. Tubulointerstitial nephritis may arise from a drug allergic reaction, an inflammatory response to an infection, a glomerular disease, or an autoimmune disease. If AKI is due to tubulointerstitial nephritis, urine analysis may be relatively bland with low level of proteinuria, plus or minus red blood cells and white blood cells. White blood cell casts may be present. Urine protein to creatinine ratio is low, typically less than 1 to 2 gram per gram of creatinine, and unless there is concurrent glomerular injury, albuminuria is minimal or absent. Finally, for intrinsic causes of AKI, we may also have problems with blood vessels, which may include vasculitis or thromboemboli. If AKI is due to vascular problems, urine analysis will likely have some degree of proteinuria and presence of red blood cells. If glomeruli are involved in the case of vasculitis, urine studies may also reveal increased urine albumin to creatinine ratio, presence of dysmorphic red blood cells, and red blood cell casts. Although the differential diagnosis of AKI is large, the most common underlying etiology of AKI is due to ATN, prerenal state, followed by obstructive uropathy, tubulointerstitial diseases, then glomerular diseases, vasculitis, among others. We have discussed the basic differential diagnosis of AKI. Let's now discuss how we can evaluate and manage AKI. The first question to ask in the evaluation of AKI is the time of AKI occurrence. Whenever possible, establish the time of AKI occurrence. This can help us focus our investigation to the time frame immediately before the AKI is detected. For example, in this graph, we can pinpoint that the first detectable rise in serum creatinine was on January 3, 2011. This means we should investigate on everything that happened to this patient in the few days prior to the AKI to find the exact underlying etiology. By the way, currently, most electronic medical record systems can graph the trend of most laboratory values. Next, we obtain the patient's medical history. It is important to know all of the patient's comorbidities, and if patient is currently hospitalized, the reason for admission. These histories may give us clues to the patient's underlying etiology for the AKI. Next, we systematically go through our prerenal, intrinsic, and postrenal causes of AKI and ask the patient questions relevant to each category. We start with questions pertaining to prerenal causes of AKI. Based on our differential diagnosis for prerenal AKI, the history should include any recent bodily fluid losses such as vomiting, diarrhea, blood loss, use of diuretics, any problem with reduced effective circulating volume such as acute blood pressure drop, acute cardiac history or symptoms associated with acute cardiopulmonary event such as chest pain, short of breath, dyspnea and exertion, any risk factors for acute cardiopulmonary event, any history of kidney disease, any known atherosclerotic disease, medications that could adversely affect intraglomerular hemodynamics, such as NSAIDs, use of RAS inhibitors, or calcineurin inhibitors such as tacrolimus or cyclosporin, or any known history of malignancy, recent trauma, or intra-abdominal procedure or pathology. Moving on, we ask for clues if the AKI is due to intrinsic causes. Based on the differential diagnosis for intrinsic causes of AKI, questions relevant to intrinsic causes of AKI should include any family history of kidney disease, systemic symptoms of vasculitis such as skin rash, joint pain, respiratory symptoms, or leg swelling, any new medications or infection that could cause acute tubulointerstitial nephritis, any recent use of nephrotoxic drugs or radiocontrast agents with CT, any gross hematuria that could indicate a vascular cause, such as a thromboembolic event. Finally, questions should also direct towards possible postrenal causes of AKI. Pertinent questions should include history of procedural manipulation of the collecting system or intra-abdominal pelvic surgery, any history or signs and symptoms associated with stones, intra-abdominal or pelvic malignancy, back pain, urinary symptoms suggesting poor urine outflow such as difficulty to start a stream, poor stream, dribbling, or sensation of incomplete voiding, gross hematuria, or history of frequent urinary tract infections, any use of medications that can cause urinary retention, most commonly medications with anticholinergic activity, such as diphenhydramine. Next, we need to obtain a complete history regarding prescribed and over-the-counter medications, recent changes in medication dosing, such as escalation of antihypertensive medications or diuretics, use of radiocontrast agent with computed tomography, and any recreational drug that could be nephrotoxic. There are many medications and recreational drugs that can cause kidney injury via different mechanisms. The following is an abbreviated list of commonly used drugs that can cause AKI. There are drugs that adversely affect intraglomerular hemodynamics in susceptible individuals. These include NSAIDs, calcineurin inhibitors, RAS inhibitors, and radiocontrast agents. Drugs that can cause direct tubulotoxicity include aminoglycosides, radiocontrast agents, cisplatin, CNI, tenofovir, and amphotericin, among others. Drugs that can cause rhabdomyolysis, where myoglobin can be directly toxic to renal tubules and form pigmented casts to cause intratubular obstruction. Drugs that are known to crystallize and cause microtubular obstruction when used in high dose. These include acyclovir, sulfonamides, ethylene glycol, methotrexate, and indinavir. Many drugs can cause allergic tubulointerstitial nephritis. Common ones include antibiotics, NSAIDs, allopurinol, proton pump inhibitors, and checkpoint inhibitors. Other drugs including CNI, mitomycin, cocaine, quinine, and conjugated estrogens may cause thrombotic microangiopathy. Next, we perform a physical exam. A pertinent physical exam for a patient with kidney injury should include vital signs. In particular, pay attention to recent blood pressure drop from baseline, and if available, review net fluid input and output over the few days prior to the onset of AKI. Evaluate volume status, specifically evaluate if oral mucosa is dry, estimate the jugular venous pressure. On heart exam, are heart sounds distant to suggest pericardial effusion? Are there murmurs to suggest cardiorenal syndrome? Are there abnormal lung sounds to suggest any acute cardiopulmonary events leading to poor cardiac output? Is the abdomen tense and distended to consider intra-abdominal hypertension, bruit to suggest renal artery stenosis, masses to suggest extrinsic compression of the kidneys and the urinary collecting system, any skin changes to suggest pre-renal state or associated glomerular diseases. Finally, if there is a Foley catheter in place, make sure it is patent. Finally, we go to our diagnostic tools to narrow down the differential diagnosis. Basic diagnostic tools to evaluate kidney injury include urine analysis to look for clues to the underlying cause of kidney injury. Urine analysis is inexpensive and offers great clinical clues. This should always be the very first test to obtain in any patient with kidney injury. In addition, we order urine protein to creatinine and urine albumin to creatinine ratios to give us a clue to the source of kidney injury. Is there tubular or glomerular injury, or does the kidney injury have something to do with paraproteinemia? Next, we can order the non-invasive kidney ultrasound and bladder scan to evaluate for any structural abnormality or urinary obstruction or retention. All other more specific testing may be done as needed to support the suspected diagnosis. Finally, a kidney biopsy may be considered if there is evidence of intrinsic kidney disease. A few words about the management of AKI. Prevention is key. Avoid drugs that are known to precipitate AKI in at-risk patients. For example, avoid NSAIDs in patients with known CKD or low effective circulating volume such as heart failure, cirrhosis, hypovolemia, and hypotension. Pay attention to all drug dosing to avoid nephrotoxic levels. Avoid the use of radiocontrast agent in at-risk individuals, such as those with advanced CKD or hypovolemia if possible. Communicate with the radiologist for optimal imaging study when in doubt. Optimize volume status at all times. In terms of treatment, remove or correct the underlying etiology or etiologies and provide supportive therapy. These include holding RAS inhibitors if applicable. For patients on metformin, hold this medication due to the increased risk of lactic acidosis in patients with severe kidney injury. Treat complications including electrolyte and acid-base derangements. Renal dose all medications. Optimize hemodynamics, including blood pressure support and hydration as needed. Provide nutritional support and kidney replacement therapy as needed. Kidney replacement therapy may be considered for patients who have severe kidney injury who cannot keep up with fluid balance and/or suffer from severe acid-base and electrolyte disturbances. Most common indications for the acute initiation of kidney replacement therapy include volume overload, not adequately responding to diuretics, hyperkalemia despite maximal medical therapy, severe uremic symptoms such as altered mental status or pericarditis, severe metabolic acidosis in the presence of oliguria or anuria, and toxin ingestion. At this time, you should be able to discuss the clinical significance, differential diagnosis, evaluation, and management of AKI. You should also be able to promptly recognize, evaluate, and manage AKI. The end.